I want to talk about a really dark case that brings together two worlds I talk about a lot, psychology and adoption. It's a case from the attachment therapy world, and I think it shows us what can happen when a clinician becomes so focused on one explanation for a child's behavior that they stop seeing the whole child. This is the case of Candace Newmaker, a 10-year-old adoptee who died in 2000 during a so-called rebirthing session that was being used as an attachment-based intervention. Candace was wrapped tightly in blankets and pillows while several adults restrained her. The idea was that she was supposed to fight her way out of the womb, essentially reenacting birth so she could be reborn and then attached to her adoptive mother. Candace repeatedly said that she couldn't breathe. She wasn't released. She eventually lost consciousness and she died from asphyxia. There's no clinical interpretation that makes that acceptable. What I find particularly important about this case is the way that Candace's behavior was being understood through an extremely narrow attachment framework. When a clinician becomes committed to one explanation for a child's behavior, there's a really dangerous possibility. The child's behavior stops being information that might challenge the conceptualization and starts becoming evidence that the conceptualization is correct. If Candace resisted, that could be interpreted as attachment pathology. If she rejected the intervention, that could be interpreted as an inability to trust. If she became distressed, that could be interpreted as evidence that the intervention was reaching some deeper attachment wound. And suddenly the child's no isn't necessarily being heard as this is hurting me, it's being interpreted as this is the disorder. That's where the clinical conceptualization becomes incredibly important. A conceptualization is supposed to help us organize and make sense of the information we're getting from a client. It isn't supposed to become a closed system where every piece of information gets forced into the same explanation. Because when your conceptualization can't be challenged by the client's behavior, you've stopped really assessing. You're confirming. And Candace was a child. The adults around her had substantially more power to determine what her behavior meant, what treatment she received, and whether her resistance was considered meaningful. She was also an adoptee, which really matters. And it's not because adoption automatically creates pathology, but because adoption involves a real history of separation and loss that needs to be understood within the child's broader developmental and relational context. We cannot reduce a child to an attachment diagnosis and then use that diagnosis to explain away everything that they're communicating. We have to consider trauma, development, family relationships, environment, culture, medical factors, the child's own understanding of what's happening, and what the child is actually telling us. Children communicate through behavior, but behavior is not a one-to-one translation of an underlying diagnosis. A child resisting treatment doesn't automatically mean they're resistant to attachment. A child being angry doesn't automatically mean they're dysregulated. A child refusing to participate doesn't automatically mean they're avoiding the very thing they needed. Sometimes resistance is information. Sometimes it's a boundary. Sometimes it's fear. Sometimes it's disagreement. And sometimes it means our conceptualization is wrong. That's the part of Candace's case that I think clinicians need to sit with. The danger wasn't simply that an extreme intervention was used. It was that the adults had constructed a conceptualization in which Candace's distress could be interpreted as a reason to continue rather than a reason to stop. And that's a terrifying clinical failure. Our job is not to make the child fit our theory. Our job is to keep revising our understanding until our theory fits the child.